My name is Vusumuzi Sibanda. I'm a registrar in trauma and orthopedics at the William Harvey Hospital, which is in East Kent, in the southeast of England. I'm going to present a closed loop audit and a quality improvement project that we did in our department. And the title is Quality of Documentation and Management in Pediatric Supracondylar Fractures. So as a background, supracondylar fractures, they are the most common elbow fractures in children. I'm sure if you work in a hospital setting or if you've been on an orthopedic ward, you've seen quite a number of children who come in with this type of fracture. The mechanism of injury is they occur mainly as a fall on an outstretched hand. And the reason why we as orthopedic surgeons are concerned and worried about the management of this injury is because if it's not managed appropriately, there's associated significant morbidity in the patients as they grow older into their adolescent and age and adulthood as well. So complications of supracondylar fractures include, but are not limited to, neurovascular injury, in particular risk of injury to the ulnar nerve, to the median nerve, risk of compartment syndrome, the risk that even if the fracture unites, it will not unite or heal in a normal position, which is what we call malunion, which results in deformities and stiffness. So we had a search through literature, and we came across this paper that was published in 2021, which showed some of the reasons for litigations or for medical legal issues in orthopedics and trauma surgery over the last 10 years in the NHS. So reading through this paper, we found out that quite a significant number of complaints or claims raised against doctors in the NHS were to do with neurological injury. There was high risk of being sued if the patient for some reason developed a neurological injury. And based on this, we sought to see if our documentation or our compliance in terms of documentation was in keeping with national standards. So the British Orthopedic Association has come up with standards of management of supracondylar fractures, which are called the BOST guidelines for supracondylar fractures management, which is the picture that is outlined on the left of your screen. In particular importance to us was whether there was neurovascular status documentation when the patients came to A&E, and immediately before we took them to theater for surgical fixation or manipulation, and after the operation. And the BOST guidelines clearly document what needs to be documented. They say you need to document radial pulse, capillary refill time, the radial nerve, median nerve, and ulnar nerve function. And they also recommend that surgical fixation or surgical management of these fractures should be done within a day of injury. And they highly discouraged operating during nighttime for these injuries. So the aims of objectives of this quality improvement projects were to ensure that our management and documentation for these fractures was in compliance with the BOST standards. And we also aimed to improve documentation and management as well. In terms of methodology, we sought ethical approval from our local clinical audit department, which was granted. We included patients who had presented with closed supracondylar and condylar fractures to the elbow. We excluded patients who had open fractures, also excluded patients who came in as adults. So our focus group was mainly pediatric patients. And in terms of materials, we had to look through patients' notes, electronic discharged notes. We had to look through the PAC system, which is our system that we use to store X-rays and radiological images. And all these sources of data were used in compiling the data and analysis as well. So our first cycle was, we looked at patients who had been treated with these injuries from January 2018 to November 2020, which was almost close to a 3-year period. That was our first cycle. And over that time period, we found 48 patients who had been treated with this condition, with a male to female ratio of 27:21, The mean average age for those patients was 6.4, the standard deviation of 3.5 years. In terms of the results, in terms of the fracture types, the majority of patients presented with Gatland type 3 fractures, and followed by those that had Gatland type 2, as well as those that had Gatland type 1. 42 out of the 48 patients had operative fixation, with 36 having manipulation under anesthesia and K-wiring. 4 had open reduction internal fixation with cannulated screws, and 2 had manipulation under anesthesia and application of casts. And the average time to surgery was 1.3 days, which is in keeping with the British Orthopedic Association guidelines. In terms of documentation, in our first cycle, we discovered that before application of backslap, or at the time of initial contact with patients, the majority of patients had their neurovascular status documented. However, it was documented incompletely. So clinicians just documented these findings as neurovascular intact, which is not acceptable according to post guidelines. Only 19 patients had full neurovascular documentation, and 8 had no documentation at all. Then following surgery, we found that most of the patients did not have clearly documented neurovascular status, with 21 having no documentation and 16 having full documentation. The time to follow up for these patients in the first cycle was 74 days. 3 of our patients were lost to follow up, and 3 of our patients were followed up out of our catchment area. So the patients who would have come from another catchment area, another geographical area, then they get fractured or injured in our catchment area. We fix or treat them for those injuries. Then they are repatriated back to their original place of stay. So these patients, we don't know what happened to them because their follow-up was out of area for us. And in the first cycle, we found out that 2 of our patients developed ulnar nerve pulsing, and 4 developed elbow stiffness. After the first intervention, after the first cycle, we sat down and decided that we needed to do something to improve the situation in terms of documentation. So what we did was we created a supracondylar fracture assessment proforma, which was aimed to improve and aid in documentation. This was made available both online and as paper form, and it was provided in the emergency department, as well as all orthopedic areas. Then we also did multidisciplinary teaching sessions targeting members of the emergency department, as well as the trauma and orthopedic team. And our aim was to repeat the audit process to reassess compliance. So this is a proforma that we came up with, which showed what needs to be documented. We put simple diagrams that anyone can understand in terms of where to assess for the different nerves that are in the upper limb, as well as to teach how to document and grade the different classes of supracondylar fractures according to the Gatland classification. And this was supposed to be done at initial contact with the patient and after surgery as well. The second cycle ran from January 2018 to November 2020. And in this cycle, we found 26 patients who were eligible for study with a male to female ratio of approximately 2:1. The age range was similar to the one in the first cycle, with a mean age of 6.5. Find out that majority of patients, 50% of the patients, had Gatland type 2 fractures, and 46% had type 3 fractures. All of our patients in this cycle received operative management, with 24 out of 26 having manipulation and K-wiring, and 1 had open reduction internal fixation with plex and screws, and 1 had manipulation and application of cast. And the average time to surgery was 0.96 days, which again is in keeping with the set guidelines. There was slight improvement in the standard of documentation in this cycle, as we found that post-operatively, the majority of our patients were getting some documentation, some neurovascular status documentation clearly written in the notes. So in comparison between the first and second cycle, when we looked at the pre-reduction neurovascular status, we found out that there was a slight decrease in the patients who had no neurovascular status documentation. The decrease from 17% in the first cycle to 12%, with an associated increase in those documented as neurovascular intact from 44 to 69%. After application of the backslap or after initial manipulation, we found out there was an increase, slight increase in the second cycle of those who had full neurovascular documentation, which increased from 33 to 35%. The slight drop of those documented as neurovascular intact from 17 to 15. However, our greatest area of change or that we noted was with post-operative documentation, with a drastic drop of those patients who had no neurovascular documentation, dropping from 55% in the first cycle down to 27% in the second cycle. The time to follow up for these patients in the second cycle was 51 days. And this time around, there were no documented neurovascular complications in the follow-up period. So in summary, what we found out was that the quality of documentation was not in keeping with the British Orthopedic Association standards for trauma guidelines. We then did a follow-up survey amongst the orthopedic doctors in the department, which showed that most clinicians, they tend to examine their patients when they initially see them before they take them to theater and even after theater. But a lot admitted that after this assessment, they do not routinely document in the notes, which meant that we need to do more to ensure that there's culture change and to encourage people to document their contacts with patients. Conclusions from this quality improvement project is that we noted some early improvement in the documentation, but there's definitely room for future progress. We also noted that performers can be an effective tool in implementing positive change. Most people were documenting the examination findings, but they were not documenting them according to the standards that are required by the BOSS guidelines. So things like performers, they stimulate people or clinicians to help them not miss things that could be obvious that could be obvious, sorry. Then there's also need for continuous clinical education across the multidisciplinary team managing trauma to ensure that people keep up to date with the standards and they know what needs to be done. Then in terms of our management of supracondylar fractures, we found out that most of our patients were getting the right treatment done. The recommended treatment for these fractures is close reduction with percutaneous K-wiring, which the majority of our patients were getting. And it's recommended that these fractures need to be fixed or managed within a day of the injury. And in both cycles, this was being done within a day of the patients coming to hospital. And the follow-up period was also in keeping with the national guidelines. So in summary, we are offering the appropriate treatment to the appropriate patients at the appropriate time for these injuries. These were our references for this quality improvement project.